patients often say to me, so are you going to do CBT with me? And I say, listen, you won't know what I'm doing, because you don't need to know what I'm doing, but I need to know what I'm doing.
Yeah.
Yeah, I often say to my patients, you're probably not going to like me very much for a little while, but that's okay.
Fell into a scrolling on TikTok hole many times.
Oh, listen, we're all guilty of that, Charlie. Great, but this is your brain. This is your brain. Like, if this thing goes down, everything else goes down because it controls everything. There's pro-anorexia accounts on social media. And
what? Wait, hang on. I didn't even know that.
There's people that will talk about anorexia as a good thing, or yeah. So that can never be a good thing.
No. Welcome back to the Not Quite Pod. Today we've got Mark with us. Mark, do you just quickly want to introduce yourself and let everyone know a bit about yourself?
Yes, so I am Mark Rackley. I am from Dublin. I've been living in London for the past 14 years, and I am an adolescent and adult psychologist. So I've been doing that job for almost 20 years now, and I was in the NHS for 7 years as an adult psychologist, actually. And now I have my own practice in Southwest London where I treat adults and adolescents. I deal with all areas of mental health, and very blessed. I love my job. I think you kind of have to if you do my job. Mm-hmm. If you don't love your job, then you won't be very good at it. So I do a lot of other work as well around. I have my own podcast called I Have Issues. I've done media around. I was on back in the day. I was the psych on Big Brother. I've been on Good Morning Britain. I do stuff with magazines and radio. So bit of a mixed bag, yes, and jack of all trades when it comes to psychology.
Hang on, that didn't come up in my research. You were the psych Big Brother. Wait, hold on.
Yeah, back in 2012, I did a whole season of Big Brother and Celebrity Big Brother. Every Sunday night, they used to, not anymore, they don't do it, but they used to do a psychology show every Sunday night live. And we would break down the psychology of what went on in the house that week. We'd interview the evicted housemate to be a celebrity on it. Alice Devine used to front the show at the time. And so, yeah, that was
wow.
Back in when it was on Channel 5. So, never thought I'd be doing that when I was training to be a psychologist. But there you go, huh? Such is life.
Wow. So what was that? What was that like? What did it sort of entail?
So it entailed, Charlie, me sitting in front of my television every single night with a notepad in my hand, making notes on the show and what I was seeing psychologically in social dynamics and what was happening in the house. And so I do that every night. And then every Friday we'd have a chat with the production team around the content for the show on the Sunday night. And then we'd edit down the clips, and then we'd do the script, and then it would go out live on Sunday night.
Wow. Wow. Do you out of interest, I mean, I'm going a bit off script here.
No,
out of interest, do you use like not tactics, that's the wrong word, but like skills like that in day-to-day life of like analysing situations and being like, okay, this is why this person reacts in this way, this is why this is happening?
Yeah. I try not to, Charlie, because I try to just go with the flow. That's what I quite like to do. But sometimes I think just because my brain is wired now a certain way, because obviously if I'm working with my patients, then I'm analysing what they're saying, I'm analysing what they're not saying, we're looking at body language, we're opening up conversations. So I sometimes will have moments where if I'm in a moment with a situation where I won't say it out loud, but in my head, I'll often say, I think this is what's going on here.
Yeah. Do you also get people people coming up, finding out what you do for a living and then asking you questions and being like, I've got this problem, what do I do about it?
Constantly, Charlie. Constantly. sometimes don't tell people what I do for a living because I will basically end up in a consultation at weddings. I got stuck on an airplane next to somebody once that basically like, I didn't say a word. I was reading a book and he's like, he says, excuse me, are you a doctor? I said, well, I'm a psychologist. And that was it. And I thought, why
Oh
did I say
God!
that?
And you can't escape on a plane. You can't escape.
I'm stuck on a plane. So, and you can't be rude. So, so that happens all the time. Yeah. And I get it. I get it. It's a bit like I've loads of my mates are like doctors and it's the same as, oh, I've got this lump on my arm and I have, you know, so yeah, I think it's inevitable when, yeah, cause people are interested in the subject, but also, most of us either have some experience of mental health or know somebody who has. So, if you have somebody sat next to you on a plane or at a dinner party, it's like open season.
Yeah, I can imagine. I must admit, I'm so glad that none of my areas of that. I won't to say that I get interrogated because I've got a disability. So everyone goes, "Oh, you've got a disability. So how does that work?" Or my personal favourite, "What happened to you?" And you're like, yeah, that kind of just happened. I think it's the thing of being younger and being out and about. People are like, you're in a wheelchair, but you're like 25. Why are you in a wheelchair?
Yeah. Some people also, they're not the most tactful when it comes to, dealing with people, I find.
No, I've had one of my worst not worst encounters because I just sort of laughed it off, but I've never experienced anything like it. Is I had a friend or like a friend of a friend come up to me, first time I'd ever met them, and essentially came up to me and was like, how is your mental health not worse? And I'm like, huh? Hang on. What? It was a big shock. It was also it was a party sort of thing. So everyone had a few drinks. I'd literally gone to the bar to grab another drink and got ambushed. I was like, okay, I guess we're having this conversation today.
Yeah, but also that's such a silly thing to say because there's an assumption there, isn't there, that because you can't hide your disability, it's so visible that somehow you must be miserable. And I just think, like, where are you joining the dots with that?
Yeah. 100%. But coming back onto the work that you do, obviously in the work that you do and in the research I found about you utilise so many different styles of therapy and techniques. What are all the different styles? Because I think everyone kind of, not all of them, because I know we'd be here for hours, but I think a lot of people kind of see it under one big blanket of like, oh, you're a shrink, so this is what you must do.
So there's loads of it's a great question, Charlie. So fundamentally you're working with the brain, and so a lot of your knowledge is based on human development of the brain, and also development of the brain through the lifespan. So if I'm working with my adolescent patients, then their brain is different to an adult brain because it's an adolescent brain to brain development, and adult brains are fully formed. Or if my patients have neurodiversity, then a brain with autism or ADHD is very different from a brain that doesn't have that. So you're working with the brain in terms of the actual neuroscience side of it, which I love, by the way. I'm a massive love neuroscience. So great stuff. And then what you then apply then is psychological models to help you understand then the psychological way that the brain works. So the brain, as much as it's kind of built by the structure of the brain, the biggest thing that influences the brain in terms of how it then internally develops in the networks and personality and the way we say mentally healthy or not is the environments we grow up in. So genetics plays a smaller role in what influences the brain's development than the environment does. So we need to understand, okay, what's what happens in this person's environment, what happens in their childhood, and we look at all of that stuff. So the models that come out that we use are based on researching all of that stuff. And then so how can we then help a patient who's unwell get better?
Yeah.
And so we have models like CBT. So CBT is a behavioral model that's based off of looking at the relationship between thoughts, feelings, and behaviors. And so it's very much based on the immediate problem and trying to tackle the immediate problem. So that's great for things like phobias and for anxiety, that kind of stuff. If you're dealing with something like, say, trauma or PTSD, you might use something like a psychodynamic approach. So psychodynamic approach is looking at the dynamics of the brain. So things like the unconscious, how we make sense of the world, how we are in relationships and how our relationships form, and also how then we understand the world in terms of our own individual makeup. So you might use that. Or a person-centered approach, that's Carl Rogers. I'm sorry, I feel I can give you a psychology lecture here.
No, I'm loving it.
Yeah. So, Carl Rogers was Californian psychologist, and his idea of person-centered was very much about that every person seeks to have individuation and to self-actualize, and he talks about conditions of worth. So very much around the individual and the individual in society. And then IPT, interpersonal therapy, that's broken down into IPT for adults and for adolescents. That looks specifically at depression, and it's been modified for other conditions as well, but predominantly depression. And that looks at how depression happens within interpersonal relationships. So specifically looks at that particular aspect of depression and other areas of mental health too.
Actually, there's just so many different it's so many different types, and also like,
yeah,
I think it must be. Obviously, you've been doing it for years, but to automatically determine what may be the best starting point for an individual, it must be like going through a massive checklist.
It's funny. I often say to my patients often say to me, so, are you going to do CBT with me? And I say, listen, you won't know what I'm doing. Because you don't need to know what I'm doing, but I need to know what I'm doing.
Yeah.
So I'm not going to say, oh, this and this and this. So the approach I take, Charlie, is I very much integrate. So the work because we know every brain is, it's a bit like your fingerprint. Every brain is different because it's uniquely wired. So when I'm working with my patients, it's totally bespoke. So I need to understand, okay, who do I have in front of me here? And then I tailor their treatment according to what I think they need.
How long are your sessions usually?
So each session's an hour, and the reason we do that is we don't want the appointments can be very intense, and they can be very. I often think like if you go to therapy properly, then therapy's hard. It is tough, really tough, and I often will say to my patients, if they're going to come into treatment with me, I will warn them and say, this is not going to be easy and you are going to find this very challenging. And I feel I have to say that because sometimes there's an expectation while you just go and sit on a sofa for an hour and you come out feeling amazing. I'm like, well, that's maybe the Hollywood version of therapy, but ask any of my patients, it's the last sofa they want to sit on. They'd rather be on their own sofa. So it's tough. Therapy is tough because they're hard conversations. You're dealing with areas of your life that you maybe don't want to talk about or problems that are very difficult to put words to. So I have the utmost respect for anyone who goes to therapy because that is not an easy thing to do.
100%. And I think as well, having had friends and that go through it, It's also challenging some of like your core beliefs. Like you'll have this belief system that you have, and it's something that you rely on all the time. And then a psychologist comes in and gives you a different perspective, and you go, "Oh shit!"
Yeah, I often say to my patients, "You're probably not going to like me very much for a little while, but that's okay."
I think for me, I've always been intrigued by psychology in terms of what it would be like to see a therapist. But it's not necessarily because I feel like there's something I need help. I'm more intrigued by what the hell you guys would pull out. Because I have no doubt there's probably something there, but I haven't put my finger on it yet.
Yeah. We're very good at doing that. Like, we're very good at asking the right questions to dig. Yeah. We dig.
100%. But I have to ask as well, you've gone from working in the NHS to running your own practice. Obviously, the NHS is under an extreme amount of pressure, which then means anyone that works within it is also under an extreme amount of pressure. What was your experience of the NHS? Obviously, we know that so much of the mental health space, particularly for the NHS, is overwhelmed. Like, there's so many people seeking support. What was your journey like with it?
I want to be very diplomatic here.
Don't have to be.
I don't have to be, yeah. Just in case any of my ex-colleagues see this. I think when you work as, I think, any doctor in the NHS, you're at the coal face of kind of the work, and because you're patient focused, and your job is to help people and support them through their illnesses. And the unfortunate thing is it takes 6 years for us to qualify, so it's a long time. And so you don't get psychologists through uni quickly, no more than any other doctor. So it can take a while to get people through the system. And unfortunately, for the demand for our services, based off of the staff that we have, but also the money that's available to staff those services, it's just not enough. It's nowhere near enough. So, like, when I was in the NHS, there was always a waiting list, always.
It's mad as well, and I know from working in, from work I've done before, the waiting list, particularly like you work with adolescents, I think of CAMS and I'm like, oh my God, the amount of pressure on you guys, and it's like a 2-year waiting list.
Yeah, and it's tough, and of course we don't want that. Like, I know I can only speak for myself, but like we wanted to get patients through the door quickly as well. Like, we wanted to, to see people quickly too, but the nature of the services is it's just not possible. Like, you'd have to maybe triple the staff of a service, and of course there isn't the money to do that. So what you end up giving the best care you can give, but it's maybe not it's not maybe the type of service that people expect. But I suppose the doctors we're trying our best to work with the conditions and the services that we can give, but it's very challenging. It's very, very challenging. And I know certainly for myself, I found that challenging because we're also limited in the amount of times we could see people. So, when we can't keep patients for very long term, but also sometimes you'd have a patient come in and they would have so many problems. You'd be thinking, which one should I focus on? Yeah, because it's not just one thing; it's lots of things. So, it can be very. And I'm not in the services in the NHS anymore, but I've the utmost respect for any doctor that's in there and does it, because it's not easy. Yeah.
100%. And I think I'm always mindful, having obviously used public services quite a lot for wheelchairs and stuff like that. I'm always very conscious of the fact that it's not the poor person that's picked up the phone or the poor person that's taken the appointment's fault. It's a wider problem that needs tackling.
It's up and up and up and up. And fundamentally, it comes down to funding. It's the funding that, and it's very well known, Charlie, that mental health services get less funding than physical health services.
I suppose as well, it's because I don't know this, but I would imagine from the outside world, it's kind of newer. Like, it's obviously a physical problem, like you've chopped your arm off. It's pretty obvious that you've chopped your arm off. Whereas with mental health, it's a very silent thing going on that people may not realise.
It is, yeah. And also, it's not, it's very different to physical health in that, we can say with certainty when you're going to get better. We just have to stick with the course of treatment that we can give you that we hope will get you better. But like, I can't say to a patient if they come in to see me, well, we'll have your PTSD cured in 12 weeks. Like, that's ridiculous. It's gonna, we're going to, we'll go into the process and we'll do our very best, and we won't keep you in treatment any longer than is necessary, but we can't give you that kind of trajectory. And I think that's the difficulty with mental health and funding, is that, patients can be in treatment longer than maybe the services can fund, and then that's what becomes an issue. Yeah.
Because I think I've got a friend that's going through it public, and they're only being offered, I think it's 12 sessions.
Yeah.
And then and it's like, you've got 12 sessions to fix this problem. If you don't, good luck.
No, and it's kind of, I mean, it's better than nothing, but you're not necessarily going to get that patient to good mental health within 12 weeks. That patient might actually need 24 weeks or even longer, depending on the nature of their problem and also how long they've had it. So, it's very challenging. Yeah.
How would you, this is a very big question, so I'm not expecting you to get the perfect answers, but how would you fix the NHS if you could?
Oh, that's a massive question. For me, like, I suppose because of my area of speciality, I kind of look at things very much in terms of, okay, well, where are we seeing the problems here? And if you look at just men's mental health alone, suicide is the biggest, it's the biggest cause of death for men within the 25 to 40 age group. And for me, then, if you know that this is killing more men than cancer, then why aren't we putting all the money into dealing with that problem? Because this is obviously a massive problem that men are taking their own lives, but we're not funding it the same way we're funding other diseases that are taking people's lives. So I would want to see parity, and I would want to see an acknowledgement that the money can't just go to and I'm not saying that the money needs to go, but it can't just keep going to the diabetes services and the cancer service. Yes, they all need the money. Of course they do. But there's other conditions, other disorders, other illnesses that may not fall into physical health problems. But if we're having high mortality rates in other areas, then shouldn't we be funding those services to bring that mortality rate down the same way we're trying to bring the mortality rate down with cancer and all these other conditions? So for me, that really bothers me, because I don't understand the thinking around that. I would get it if the mortality rate was really low when it came to men's mental health, but it's not. It's just not. So I feel there's still a large amount of work to do there around just the recognition of, like, this is not going away, and this is actually not coming down. But part of the problem is, I would think, because we're not funding that well enough to be able to provide quality services to bring that down.
Do you think there's an element of, like, I always think, because for me, I always think of the youngsters. As I say, there's been a huge spike in young people struggling with their mental health. Do you think that something we can implement earlier on to almost put a pin in it before it happens, if that makes sense? So I know, obviously, mental health's a very wide spectrum and you can't prejudge everything that's going to happen. But do you think there's something we could put in place for young people to sort of mitigate what they go? It's hard. I don't know how to phrase it correctly, but like, so we can improve their chances of not having the difficulties that they have later down the line.
Definitely. So for me, what I'd love to see is mental health being taught in schools.
I'm with you there, 100%.
And 100%. I can't understand, like, my first placement was in a school back in Dublin, in a really dodgy school in a dodgy part of Dublin. And it was a baptism of fire. And the work we did was proper, like, big work with the kids we were seeing, because they were from socioeconomically deprived backgrounds and loads of problems. And so and for me, like, if we could get your mental health onto the curriculum at schools to help children and teenagers understand, okay, this is what your brain looks like, this is why your brain works. If your brain becomes unwell or this happens, this is what can happen. And I feel we could do preventative work then rather than crisis work.
Yeah.
So for me, if the knowledge is the key, and of course schools are all about imparting knowledge. So I think if we're going to impart knowledge around sex, and I know sex education is coming down anyway, but whatever. But if we're going to impart knowledge around sex education and we're going to give knowledge around loads of other things, then I feel mental health should be a massive component in teaching you, because we're the ones that do the teaching. We're the ones that end up doing it. But like, when the young person's in my office, we're already at crisis. And sometimes we're at really big crisis. And, like, that's not good for anybody. So I would rather do preventative work, which I would see the schools playing a vital role in that.
I think you're 100% right, and it was part of a discussion that I was having with a friend earlier today. And it's that whole thing of there's so many parts of the curriculum at the moment where we focus on stuff that's not really, I'm going to get a lot of hate for this, but not really relevant. Like, I would come back to the whole thing of, like, everyone uses algebra as the example, but it's just the one that comes to mind. Algebra has its place, but then if we look at it from a bird's eye view, what's more valuable to learn? How to look after your mental health, so then whatever career you go into, you're better equipped to go into it. Learning about your body, if we're talking about the sex education part of it, learning about your body so you understand how everything works, what the social side of that comes in and everything else that goes with that. Is that not more beneficial because it prepares a person for whatever walk of life they go into, rather than, if we take algebra for the example, there's a very specific set of jobs where you're ever going to use that skill. Other than that, it's not really valuable.
True. Absolutely. Yeah. Whereas mental health, that's with you for life.
Yeah. So. I mean, also, it has a huge impact on everything else. Relationships, work, libido, if we're going down the sex education, libido. Like, there is just a huge plethora of, it's so frustrating. But I think this was something I was going to come on to with you, is also mental health still treated as like a woo-woo topic. So, like, if I use it in my context, I love my parents to bits, but mental health is not something they get. Yeah. They're very much from the school. They're both self-employed, both grew up in rough parts of London. Like, it's very much like, oh, shut up and get on with it. Or it's like my dad's favourite one was, best cure for a common cold is self-employment. And that's probably a prime example. And I think that's the other thing as well. It's this whole thing of mental health still being quite woo-woo and like, oh, shut up and get on with it. We need to get away from that. Because unless you've experienced it, you don't really get it. I think that's the other thing I realised when I went through it. I was like, whoa, this is like a whole new world.
Yeah. I couldn't agree more, Charlie. Like, one of the things I don't understand, I don't understand lots of things, but, like, people seem to forget that when you're dealing with your mental health, you're dealing with your brain, which is the most powerful organ that is in the body. So like as much as and which I'm all for, of course, like we tell people to, put SPF on to protect your skin, or don't drink too much to protect your liver, or don't eat too many kebabs to protect your heart. Like great, but this is your brain. This is your brain. Like if this thing goes down, everything else goes down because it controls everything.
Yeah. Yeah. It's
not, it's like, but you can't see it, but as you just said, you will know.
Yeah.
Very powerfully so, depending on what's going on, if it's not working.
I mean, your body will tell you. Like, if you take me, for example, when I went through it, I was hyperventilating in my sleep.
Yeah.
That's a big red flag. And if it's ever happening to you, go seek some help. It's
totally, because it's like this thing with your mental health is if it goes down like any other illness, you're going to get symptoms, and I think that's the problem. Is like lots of people ignore the symptoms. So if I get a patient that comes into me in crisis, like most of the time they've had the symptoms for a long time. They just haven't been dealing with the symptoms yet. Do
you think that's partly because of the stigma that comes with therapy, though?
Yeah, it can be that there's still a bit of a taboo around dealing with feelings and crying and being seen as weak, and it being seen as, well, you should be strong enough to be able to cope with that. And I always get so frustrated with that. I often think, well, like, imagine saying to somebody who has been caught up in a terrorist attack or some awful horror in their life, well, could you not just get over it? Like,
yeah. So just stop being depressed.
Yeah. Could you stop crying every time you're triggered? Like, it's ridiculous.
Yeah.
Because that's just not the way it works. And for people especially who've experienced trauma, they can't control the triggers because the triggers are out of their control. Yeah. So like, you're asking people to fail by not dealing with it, which is you would never do that to somebody else. Yeah. It's like, well, just stop whining about that tumour in your head. Sick of listening to you. Just wouldn't do it.
Yeah, you're 100% right. It's like, stop whining that you've broken your leg.
Yeah. It's like, just wouldn't. And I think, like, again, that's where, like, I think it'd be Mental Health Awareness Week. Like, that's why we need all that awareness, which is like this is illness. Like we don't train for 6 years to learn how to do nothing. Mm-hmm. Like we're trained to actually understand and help people get better because they're not well.
Yeah, 100%. And I think as well, like we've touched on younger people, but I think there's such a big thing in the corporate work world when it comes to mental health, because there's it still comes back to I know it's a buzzword, but the hustle culture of like just keep going, and people suffering with burning out. How much of that have you seen with clients of coming in and just being like, I'm under so much stress at work, I don't know where to turn next. What the hell do I do?
I've seen so much of that. I did a podcast episode on it.
There you go, and I will link it below as well.
There's literally a specific episode just on burnout. Because the thing about burnout's really serious, Charlie. Like, I know sometimes people don't really understand it, but burnout, for some people, they don't come back from that.
Yeah.
Like, burnout can be life changing. So if you're dealing with extreme burnout in some patients, they never get back to that level of functionality again. Like, it has that much of a detrimental effect on their nervous system and their brain. And it's awful because now it's almost like it's disabled their life.
Yeah. I suppose it's that whole thing of it's your brain trying to protect you from something. So if a traumatic experience happens, your brain can try and turn it off. So I imagine it's the same thing of like, we don't go past this line anymore, understood?
Yeah. Oh, totally. Like I'll often say to my patients, Charlie, like you can't tell any part of the body how to work. Like it works independently of you. So you can't tell your heart how to work or your pancreas or your gallbladder, and you can't tell your brain how to work because it works independently of you. So if you push it and think, oh, it'll just keep responding, it'll just keep cooperating with me, it won't. It won't
Yeah.
because it's hardwired to keep the body alive. So if we're making choices or living lifestyles where the brain goes, I've had enough of that because the body's at risk now, you never win.
Yeah.
Nobody wins that one ever.
Yeah. Yeah. What would you say to like the hustle culture thing? Obviously, you've worked in the NHS, extremely high pressure. You now run your own business, which I imagine comes with its own pressures. What do you say to hustle? I think the hustle culture gets a bad rep, but then also it's that whole thing of I think like if you're doing your own thing or trying to do your own thing, you can't constantly feel like I've got to keep pushing because I've got to keep making it better, and then you end up in a bit of a spiral.
Totally, Charlie. I think the thing with that is like it's that old idea of it's a work-life balance. Like if you're going to work hard, grant, no issue with that at all. But you've got to compensate for that by making sure that your life is having other moments of relaxation, wellness, downtime. So like if you're trying to function on 5 hours of sleep a night and you're working like a lunatic and like you're pushing and pushing and pushing, like that just won't work.
Yeah.
You're just not gonna, you're not gonna get away with that long term. Like that, the body will start to fail because that's not sustainable.
And I suppose it comes back to that old analogy of the tortoise on the hare.
Totally, yeah, totally. Which is, it's so true. It's like, again, you won't win when it comes to telling the body how to work. You'll never win that one.
Talking of managing your mental health, though, how do you manage yours? I mean, you deal with some very, I can imagine, very harrowing conversations with clients, and they take you on a very deep and dark path occasionally. How do you compartmentalize that? Because you might be told something that you're like, whoa, okay, this is a whole new level. How do you deal with that?
Yeah, it's a good question, Charlie. Obviously, we're human, and some of the stories I hear would break your heart and would make you give up hope in humanity because they're so awful. And like if I'm listening to something particularly harrowing, I'll often say, and I'll mean this genuinely, I'll often say to the patient that was really hard to listen to. And the reason I say that is because I want to validate that this is awful, and it's so awful it's affecting me. Yeah. Now, I'm not saying that to make the patient feel uncomfortable. Quite the opposite, actually. That's actually said from a place of empathy, because I want them to know that, okay, just because this is my job, and maybe I've heard a lot, which I've probably treated thousands of patients at this stage of my career, but that doesn't mean that suddenly I'm just this like impervious wall of great mental health, that things don't still affect me. They do. So, and I think that's very important that people know that about you, that you're with them, but you're with them on a very human level as well. You're not just a doctor in the room that's able to hold it all. And for me, I suppose psychologists have supervisors. So I talk to my supervisor quite a lot about,
even in private practice.
Yeah.
I didn't know that.
Yeah. So I've got my supervisor, and if I need to, I'll go to therapy. So I'll practice what I preach. I will go, if I think maybe my life is getting on top of me or my mental health isn't so good, then absolutely I would go and see somebody. What I do practically as well, I make sure, like during the week, I no alcohol during the week. I don't drink. I am in bed early. I run a lot. I exercise. I try and do mindfulness. I try and really take moments for myself,
Yeah.
where I just, I'll stick some trash TV on,
Yeah.
or
Yeah.
I'll, I'll do all the things that I say to my patients, I'll try and do myself, because I have to stay well too. And if I don't stay well, then I can't help my patients. So I have to be really mindful that my mental health is as well as it can be. Because the other thing too, speaking of burnout, is that the rate of burnout in our profession is really high, understandably so. So you've got to be very careful that you're really keeping an eye on yourself, that you're not burning out. Or even, the guy did a podcast episode on this as well, on vicarious trauma. So it's one of the things, sadly, we're exposed to, which is being traumatized as a result of a lot of the trauma that we listen to. So you got to really watch all that stuff as well.
How do you, I don't know whether you have, but just because it popped into my head, how do you manage if you had to go to therapy to look after your own mental health, then come into work the next day, treat Sharon's mental health? How do you do that?
Honestly, it's tough. It is
Yeah.
tough. It is tough. Like, for me, like, I suppose when I'm dealing with my patients, I kind of have to put myself into the background
Yeah.
and think, right, this is about my patient. I've got to be fully present for them. And, so therefore I'll deal with myself later when I'm out
Yeah.
of the clinic. But while I'm here, it's not about me. This is about my patients. Yeah.
That makes it. I see. I mean, that's not a position that I'd be horrible to be in, having to like try to deal with your own stuff and then
Yeah.
coming
It's
into
not
every
easy.
day. Yeah,
Yeah.
no,
It's not easy. And like, the patient will never, my patients don't know anything about my personal life. I
yeah,
keep myself very separate from all of that. So they'll have no idea what's going on in your life.
yeah,
None whatsoever. So you could be having the worst time of it, and your patients will never know, nor should they, because you don't want anything that's going to compromise the work,
yeah.
and that's going to affect the quality of the work that you do.
I can. Yeah, it's almost like you've got to be a fantastic actor at the same time as being a fantastic therapist.
Sometimes, yeah, well, I reckon, there's been moments in my career where I've like, give me that Oscar, because that was hard.
Love that. I love that. You mentioned really briefly about mindfulness and the
Yeah.
lesser mainstream
Yeah.
therapies and techniques.
Yeah.
What's been your experience with that? Is that something that you brought in to your practice quite recently? How has that happened?
Yeah, so no, actually, Charlie. Back in the day, mindfulness came out of kind of the guys in California, John Kabat-Zinn. He wrote the Mindful Way Through Depression, which at the time had a CD in the back of it, which I know is like it's like dinosaur land here. So those guys developed mindfulness, clinical mindfulness, as a way to help patients who had been depressed, recovered, to stay in recovery and not relapse. And great book. I have it it's in my office. So predominantly that was to do with, that's probably going back. God, that book must be a good 15 years old now, if not long
Wow.
older. So it's been around for a while, and it's been developed and developed. And the guys up in Oxford Uni, they do huge amounts of work. Mark Williams and, the other guy, I can't remember. So they've done massive amounts of work around mindfulness and adapting mindfulness for anxiety and lots of other conditions. So it's now become quite clinical in terms of what we know about it, and what we
Yeah.
know it does to the brain, and how it works, and how mindfulness practice actually will rewire the brain if you stick with it. So it's now become quite integrated into, so it's available on the NHS. So when I was in the NHS, before I left the NHS, that was what, 7 years ago, I think, the NHS were, using mindfulness as a treatment, for certain conditions. So it's very mainstream now, and, it's not for everybody. It's not, it really isn't. But I would tend to use, I suppose, with my patients as a complementary way to help. It's as its own intervention tool to help them. Okay, well, if you're overthinking, or if you're having you think you're gonna have a panic attack, then this is what we can use just to help to calm everything down, slow down the breathing, slow down the nervous system.
Yeah.
So it's very effective. Yeah, for those that can use it. Not everybody can.
I suppose it's that whole thing of finding what works for you, really, isn't it? Is there any risks with therapy? Because I never thought about it before, but is there any risks?
Yeah, absolutely there is. So the risk, I suppose, with therapy is that it is going to possibly temporarily destabilize your head. So with therapy, there's no harm. Like, the only way you can be harmed by therapy if you're in the hands of somebody who doesn't know what they're doing or is working out of their own competence. So you can't be harmed in terms of the safe work that we do. But the immediate, I suppose, air quote, harm is that I'll often say to my patients when they leave my office, if it's been a particularly difficult appointment, I'll often say you might find that in the next coming days you might be more tearful or emotional, you might find distressing images coming into your head, or you might have nightmares. But I will warn them about that.
Yeah.
So once you tell the patient, listen, now that we've kind of started to go into your memories, or we're going into, say, trauma or problems, then the brain will work with that after you've left my office. It's still going to process it. It's going to, and also now that we've targeted it, then it's going to stay live for longer. So once you explain that to patients and you help them understand that that's part of the process, then my patients often going to go, oh God, that's exactly what happened. Yeah. So they're not surprised, but also it keeps it very safe. Yeah. And of course that only happens kind of while we're in that work, and then it all starts to settle down. But harm itself, no, again, like I said, the only harm would be if you're with somebody who doesn't know what they're doing and isn't working safely.
That's good. That's good to know. I think as well, like, everyone sees it as like, I don't know. I know they know that stuff's going to be dragged up, but it's the after effect that as well needs highlighting of going, like you say, 3 days later you might go, whoa, this thing hits you, and very tricky.
Yeah. And that's just, I think you kind of need to say that to patients, because again, that's just how the brain works. So like I often say to my patients, like, long after you leave my office, the conversation's still going on in your head.
Yeah.
So, and again, once you work with them, then like the patient then isn't surprised when something like that happens. And also you've given them the tools then, also to be able to manage those moments when they happen.
What would there's been a huge uptake in like digital resources and online courses and things surrounding mental health. What's your opinion on that, as someone that does, obviously, I know you mentioned that you do some online check-ins with clients, but you do a lot of in-person work as well. What's your opinion on it?
I think, like, suppose during COVID, I spent almost a year like this, seeing all my patients on Zoom because they weren't allowed into the clinic, obviously. And that was challenging, because I'd never done that before, never done all my appointments on a screen. And I suppose we just all had to learn to adapt to still give the treatment. And so for me, it was actually, it wasn't ideal, but I suppose as long as I knew that the patient was still receiving treatment and the patient was still okay, even if it was this medium, then so be it. You had to adapt because there was no other way to deliver the treatment at that time. But I suppose now I kind of have a mix of both, Charlie. Like some of my patients travel a lot, or I see lots of young people who are in boarding schools, so they can't always get to my office. So we use Zoom, and that's fine because we set it up and it works very nicely. But when it comes to what you were saying there about apps and stuff, like, I'm not sure, like, I'm not sure about that because, and I'm not knocking it, but the biggest predictor for successful outcomes and treatment is the relationship you have with the doctor. Like we know, we've researched this to death, which is, okay, what works? Is it this modality? Is it this treatment? Is it what works? And it's always the biggest predictor is the relationship you have with the psychologist or mental health professional. So for me, like, I want that relationship with my patients. I work very hard to establish that. And I think I would find it difficult if I was on an app to form that relation. I'm not saying other people couldn't. I'm sure they could. But for me, and maybe I'm a bit old school in how I was trained, like when you form that very close relationship with your patients, it's a gift. It's a real gift because you'll often hear, I hear this many, many times, is patients have gone to see maybe other therapists or doctors and said, I just didn't click with them and they weren't the right fit. And that's fine. And not everybody clicks with me. I totally get that. And I don't expect that they would. But when you hear that, then that's telling you something that the patient is, they will leave that treatment because they didn't feel the fit was right.
But I think that's something to be said as well for anyone looking at therapy, having had friends go through it, is do some testing, find the right therapist for you. Because as you just said, some people you just don't click with, and some people you do.
Yeah, absolutely. And some people want to speak to a guy, some want to speak to a girl, all that stuff,
What about, what do you think is the biggest contributing factor to the, I mean, again, very big question, but the biggest contributing factor to the massive increase we've seen in people struggling with their mental health?
Oh, the pandemic was a game changer. Yeah. I mean, that just did a number on us all, didn't it? Like, I think everybody's mental health hit the floor during that. And like, I think only in many years to come we'll realize the significance of what we all went through, because we all had to kind of get on with it and find a way to get through it. And so we were all kind of being very reactive to just trying to cope with it all. But I don't think we fully appreciated how, like, it was really hard to live through that, and lockdowns and being cut off from people and the fear we all had in the beginning of, is this going to kill us all? And like, just the collective trauma. So certainly from my experience, working through the pandemic and post-pandemic, like, with mental health, you're busy all the time because, of course, people are always unwell. But certainly, the pandemic really was, very difficult for lots of people.
What do you think caused, because I know I've talked about it a lot, it's just because it's something that's very close to me. What do you think's caused it more so? Obviously, the pandemic would have had an impact, but what do you think's caused it with young people? We've seen a huge spike in young people needing support with their mental health.
Again, we think it's the pandemic. So with young people, during the pandemic, they were cut off from socialization, as in they couldn't see their friends. In some cases, some of them, they missed developmental milestones. So things like, not being able to graduate, not being able to do their GCSEs, not being able to, have those kind of teenage years or teenage moments, and you don't get them back.
Yeah.
Like they're gone. And remember, for young people as well, like young people, their brains are in development. So they're far more emotional. They crave the peer group more than adults would. So, and lots of them as well, they were isolated. So all of that stuff meant that teenagers had to, they had to work really hard to get through the pandemic. And sadly, lots of them didn't have the support to get through that as well. So, what I've seen a significant rise in with teenagers during and post pandemic is in self-harming and eating disorders.
Yep. Yeah. I had a feeling that was one of the trends that we might see.
Yeah. And that's the reason, again, I'm coming back to my podcast. I did a separate episode on self-harming in teenagers, and there's a separate episode on anorexia. Literally for that reason. Yeah.
Do you think social media has played a part in it as well? Because obviously during COVID, we were very reliant on Zoom, Instagram, Facebook to try and stay connected to people. But then also with so many youngsters, me included, I mean, I'm a content creator, using social media so much, and the good and the bad and the ugly coming from it. Do you think that played a part?
Definitely. Like I don't want to knock social media because I'm on social media. So I use social media for mental health awareness, but I suppose being an adolescent psych, I hear about social media all the time from my adolescent patients. And I think we just need to be very careful. I know it gets into trouble all the time, and I'm all for that. Like, they're getting into trouble for a reason, because some of the content on social media, like if I'm treating a patient with anorexia, there's pro-anorexia accounts on social media. And
what? Wait, hang on. I didn't even know that. That's crazy.
Yeah. There's people that will talk about anorexia as a good thing, or So with that kind of stuff, then like that can never be a good thing.
No,
just can't be. So, and also social media as well, for especially for vulnerable minds, young vulnerable minds, then especially when it comes to lifestyle, popularity, body image, then it can feed that idea that if you want to be successful, popular, desired, which of course popularity is a massive thing with young people because they're very tribal. Then, the stuff that's on social media can feed vulnerable minds this idea of this, you need to be this version of yourself to be a popular person, which of course puts pressure on that young person.
What do you think that's probably the worst element of it, is the element of portraying that you need to be this thing to be desirable, to be popular, to be successful? Do you think that's the worst thing?
I think it's one of the bad things, but I think the other thing, Charlie, as well, is social media is not real. Like, the stuff people put up there, it's not real. Yeah. So, like, you don't see the times when the person like isn't having a good day or is maybe struggling with their mental health. So I feel for social media to take it at face value is dangerous, because it's not real. It's not a real version of life. Yeah.
And I know, I have to say, being in the creative space, I know there's people trying to change that, but it is 100% true. Like, you got to remember that social media is a person's highlight reel. They're not going to show you their down days, really, because no one's interested.
Exactly. Yeah. And it's not the stuff that gets followers.
Yeah, I think it's hard with social media. It's very much like you've got to be over positive or over negative. The guys in the middle struggle.
Yeah, totally. And also, I kind of do hope, like, I don't know where we're going with social media, to be fair, but I do hope that it becomes more of a positive force. Yeah. In terms of how it's used, and also the content that people are engaging with, because some of the content on social media it's point blank, it's not good for your mental health.
Definitely, and I think as well, it's that whole chasing the dopamine as well. I always worry about that and falling into that hole myself. I fell into a scrolling on TikTok hole many times.
Oh, listen, we're all guilty of that, Charlie.
The other thing I wanted to ask, obviously, we've spoke
Yeah.
about managing your mental health and looking after your mental health. What would you say to someone that's probably listened to this, that's struggling, or a family member that knows someone who's struggling? What sort of a first instance thing that you could do to support them?
For me, it's talking. Talk. You got to talk. You got to talk, and don't be afraid to talk. So, sometimes people don't know what to say, and sometimes if we don't know what to say, we don't say anything at all. Don't do that. Like, it's better to say something than say nothing, and it's far better that the person knows that you've noticed something or you're concerned. So the message that it sends is, I'm concerned about you, I care about you, and I want to just make sure, are you okay? So for me, it's always about that first piece, which is the talking piece. So the talk, and it doesn't need to be a big deep dive into a psychological consultation of assessment. It's not that, but it can just be your own gentle observations, which is, like, I know you've been going through a hard time. If they have, how are you coping? Or just maybe more general, how is your life going right now? How are you feeling? So whatever language you use, the narrative is up to you. But if you notice something, say something. Then if the person does need maybe more kind of, professional support, then the first port of call is always your GP. So get in to see your GP, just get the GP to check you out. And then if the GP says, listen, I think we need to get the mental health doctors involved in either local NHS services, or if you want to go and see somebody privately, then, you get that help. My message always is that a question or a conversation inquiring about somebody's mental health is never a wasted conversation.
100%. And I'd say it's that whole thing, like you say, it doesn't have to be an intense discussion. It can just be checking in. And I have to admit, I'm not perfect at checking in on friends and family. I'm definitely one of those people that goes, yeah, I'll do that, and then completely get sidetracked. But it's definitely something that you need to do more of. And I think as well, it's about opening that conversation and opening the door to allowing two individuals to have that dialogue. Like, it doesn't have to be, it can just be part of when you catch up with your friend that you haven't seen for a while. It's part of the catch up. It's like, actually just checking in. How's everything going? You were dealing with this last time. How's that happened? What's happened with that? It doesn't have to be, as you say, it doesn't have to be a consultation or an attack of like, fill me in.
Yeah, totally. And what you're just saying to the person really is, like, here's the space. Yeah. And if you want to use the space, that's up to you. Yeah. But you're 100%. Creating the space, which is brilliant. Yeah.
And last but not least, I'm going to ask you the question that I ask every guest, which is, what's one piece of politically correctness that you really strongly agree with or disagree with?
So for me at the moment, I suppose I'm going to stick, because it's Mental Health Awareness Week, and also because of my job, I would like more open discussion and more understanding and less stigmatizing around self-harming and suicide.
Could not agree with that more. I could not agree with that more. One of the best pieces of advice I ever got given by a friend is, pain is relative, because they only know what an individual only knows what they've been through. You can't compare it to what you've been through, because your tolerance might be different to their tolerance because of what they've experienced. So you can't go, well, I hate it. We see it all the time in the disability space. It turns into like disability wars. You can also have mental health wars of like, well, I've had this happen. Well, I've had this. It's like, really? Are we really trying to top trump each other about this?
It's so true. It's so true. And it's like, it's not a competition about who's the most, whatever.
Who's the most depressed?
Yeah, exactly. It's not that, but it's also like everything, like, mental health is on a spectrum, and like you have some people who will be living with depression who will, through therapy and maybe medication, they can have a really good level of functioning, a really good quality of life. And you'll have other people at the other end of the spectrum who have depression, who might be actively suicidal, who may have maybe made attempts in their life and are in some people end up in hospital. So like, it's having the conversation around all areas of mental health, not just the ones that are like of the moment or that some celebrity has decided to come out and talk about. It's not that. It's actually bringing in the conversation around the mental health that everybody on the spectrum experiences, not just a select few.
I think it's also, we need to move away from mental health being, not in a bad way of bringing attention to it, but it's almost seen as trendy. And I don't like that. It's like, it's not a positive. I mean, looking after your mental health is a positive, but struggling with your mental health definitely isn't.
Well, it's not like I have never heard a patient say to me, and I never will, I chose to be depressed. I chose to have PTSD or OCD or bipolar disorder or whatever it is.
Yeah.
I've never heard it, and I've never heard it being described as, I really think it's really cool. Like, I don't think so. Like, it doesn't add to your life. It takes. So like, it's not trendy. Like, if you speak to somebody who's really suffering with their mental health, like, there's nothing cool about that.
I mean, it does worry me with your point that you made earlier about the anorexia accounts. That part of the conversation definitely sparks a bit of worry of, you never know what people are going to create, but there you go, I suppose.
Yeah. And sad thing is, like, that stuff is out there, and there's even been, with some of the social media accounts where, people have been, encouraging self-harming as a way of, dealing with your feelings. So like, that kind of stuff is like, it's dangerous. It's dangerous because, that kind of stuff shouldn't be encouraged. And also it can lead to really serious problems.
100%. And I also wanted to say thank you for coming on. I've learned so much. You've been an amazing guest.
Psychology 101, huh?
Yeah.
I hope everybody could understand me.
100%. Don't worry. But yeah, it's been amazing. I've learned so much, and hopefully everyone else will. I will link all of your details, your podcast, your work, website, everything below. So if people want to check you out, Mark, it's all below for people to find. And yeah, thank you so much.
Charlie, absolute pleasure. Thank you so much for having me. I had great fun, actually.
Thank you so much for tuning into this week's episode of the Not Quite Podcast. Please make sure you follow us on TikTok and Instagram to get regular updates about the podcast.